Requesting all delegates to be seated, we now begin our next session. For our next session, I now call upon our chairperson, Dr. Adam Falu, who is a senior pediatrician in South Mumbai. Thank you, Dr. Adam. I now request Dr. Adam to introduce our speaker for our next session.
Thank you. Welcome everybody back. Dr. Joyce Elizabeth Williams. She's a consultant in transfusion medicine at Teaching Hospital. And she's currently managing the Department of Transfusion Medicine at Sir H.S. Reliance Foundation Hospital and Research Center, Mumbai. She completed her MBBS from Government Medical College and did pathology from HPLC under University of Mumbai. And she has also done her DPT. Being a member in Asian Association of Transfusion Medicine, Indian Society of Blood Transfusion, and Immunohematology. Indian Society of Transfusion Medicine, Mumbai Hematology Group, Association practicing pathos in India. She has an experience of 12 years in teaching and 28 years in managing the diagnostic services, microbiology, and transfusion medicine in reputed multi-tertiary hospitals. She has a special interest in immunohematology and transfusion medicine. My request, Dr. Joyce, to.
Thank you, sir, for the wonderful introduction. I think after a morning session, which was really elaborate and a wonderful tea session, we moved to the area of blood banking or transfusion medicine, where most of our thalassemia children are dependent on. But knowing well that transfusion has its own problems, so between me and Nidhi, we would be actually discussing the problems that transfusion causes, post-transfusion manages, and how do we manage or mitigate these problems in the blood banking. Blood transfusion is an essential part of modern healthcare, and if used correctly, it can save life and improve health. However, as with any therapeutic intervention, it is known to cause both acute and delayed complications and carries a definite risk for transmission of infectious agents. Now, the risk of transfusion is mainly exposure of the patients to foreign allogenic antigens, leading to alloimmunization, which would be definitely covered by Dr. Nidhi, so I wouldn't be touching it. And transfusion transmitted infection does continue to be a big threat in especially developing countries like ours. I'm asked to talk about quality in transfusion medicine by Dr. Shweta. Actually, quality begins right from the vein of the donor till the vein of the patient. And it's an entire cycle and would be difficult to complete the entire chain. So I would be actually sticking to few areas where it would be important, certain areas where it would help you understand how we mitigate the risk in transfusion. It would begin with donor screening, selection, blood collection, processing, laboratory testing, storage, inventory, traceability, documentation, quality control audits, at the bedside, proper administration, more documenting of the transfusion, reporting transfusion reactions, everything. It's an entire cycle. Now, beginning with how do we begin a quality? It is actually recruitment of voluntary, non-remunerated donors. These are important because they are the low-risk donors who would definitely not hide their health issues in transfusion, which is very important. Followed by a pre-donation counseling. Actually, in big camps, this is an area which is compromised. This is important to eliminate donors with health issue risk and also donors who would with high-risk behaviors, because they are the donors who would actually increase the risk of transfusion-transmitted infections. This is an area which now is coming up, bacterial infection through blood products, which with viral transmissions being controlled with better tests, we need to look at bacterial infections. It is said that though rare, it's almost 1 in 5,000 platelets and 1 in 30,000 red cell concentrates have bacterial contamination as per the NIH study. Now, the risk of bacterial contamination in clinical relevance or, giving clinical infection is probably not so relevant because we have a rampant use of antibiotics going on in hospital admitted patients. but it is true in immunocompromised patients. Now, how do we mitigate? What are the steps taken to mitigate the bacterial contamination in blood products? One is a very basic step of ensuring thorough arm cleaning prior to the blood donation or prior to the venipuncture of the site as per protocol, so the bacterial flora in the skin do not enter the blood bag. The next is use of diversion pouches. That is, the initial few ml of blood enters into the sample pouch, so you do not have the bacterial flora entering into the primary blood bag. Bacterial screening of all your platelet concentrates, which is not done. Probably our FDA guidelines say screening of 1% of the platelets for culture or 1% of the blood products. In fact, all CAP accredited centers would know that it's a mandate to screen all your platelets for infection before transfusion. So this is one way of mitigating your bacterial risk in blood, especially platelet transfusions. I just thought of putting this slide up because this is one part of quality control is get your components prepared within 6 hours of transfusion and store it at the right temperatures to get the quality of the products that you needed. I would not be covering this part in detail. We all know that all units of blood in India at least are mandatorily screened as per the regulatory authorities for HIV-1 and 2, hepatitis B surface antigen, antibodies to HCV, syphilis, and malaria. Yet we see news like this, that there are 2,234 patients getting HIV infected after transfusion. Why does this happen? In fact, a few years back, when there was a report of around 1,000 cases of HIV post-transfusion in Maharashtra, there was a look-back study by the Blood Transfusion Council, and they found that the primary reason is because most blood banks screen by a basic ELISA test for these infections. And the innate shortcoming of these tests is there's definitely a window period that you would have. So if there's a patient who is infected or donor is infected, before it would not be detected till it achieves the antibody level. Financial constraints do not permit all blood banks to use the nucleic acid testing. Also, all blood centers do not follow a routine internal quality control or an external quality assurance scheme so that you ensure your quality of your testing. Besides, all the HIV detected donors in the blood center are not counseled, so they go around donating again and again and increasing the risk for transfusion. So we all understand that the greatest risk for blood safety is a window period donation, which accounts for more than 90% of the residual risk. In addition to window period donation, the viral variants, which are not picked up with the current assay, immunosilent donors, and laboratory testing errors add to the risk of HIV transmission or even hepatitis B and hepatitis C. Besides, we have a high prevalence of hepatitis B, HIV, and HCV in the country, the tune of 12.5 to 43 million HCV carriers in India, which add to the burden or the risk. In fact, across the globe, we know that transfused blood is never 100% safe. Even ID NAT, when used, has a small window period. But yet, we do not have countries reporting HIV or transfusion-transmitted infections to the rate that we do. In fact, in Canada, has no transfusion-transmitted infections of HIV since 1985. In US, the last HIV transmission was in 2008. In UK, it was in 2005. Then why do we fare so badly? It's because we have a high prevalence of these viruses in the community, lack of 100% voluntary repeat donors, and use of low sensitivity tests for viral screening. We do not even mandate a 4th generation ELISA for mandatory screening of leave aside NAT. So you have low sensitivity kits being used to screen our blood donors for infections. The risk of post-transfusion viral transmission is as high as 1 to 1.8% for hepatitis B, 0.28 to 0.5% for hepatitis C, 0.23 to 0.4% for HIV-1. So is there anything better that we can do? Yes. the nucleic acid testing, which definitely reduces the incidence of transmission of HIV, hepatitis B, and hepatitis C in the post-donation. It's a molecular method for screening of blood donors, where you extract a nucleic acid either by the TMA or the PCR method, amplify and detect them. The advantages of the nucleic acid method is it's highly sensitive, specific for the viral nucleic acids. It amplifies the targeted regions. It raises the bar in blood safety. And it also, besides reducing the window period, helps in detecting occult hepatitis B infection, which is a major contributor for hepatitis B transmission in our country. You can see the reduction in window period. In fact, in HIV, even with a 4th generation kit, the window period is 15 days. With a NAT kit, it would reduce to 4.5 days. In HCV, it reduces to 2.2 days from 58.3 days if you use an antibody kit. Hepatitis B virus detection reduces from 38.3 days to 16.3 days, therefore increasing the safety of blood if you use a NAT test. In fact, across the world, we have seen a reduction of HCV and HIV by using NAT. The residual risk of transmission of HCV, HIV, and hepatitis B has reduced a great deal across the globe. In India, several studies have shown that our yield, when you say of an yield, it means a unit that is tested negative by basic ELISA technique and still flags positive in a NAT test. It's around 1 in 1,000 donations. That means we infect 3 individuals by the 3 products prepared from that in unit. In fact, we have been doing NAT since July 2015, and our data corroborates with other studies. Our yield is around 1 in 1,000, predominantly hepatitis B. Majority of them are occult hepatitis B. We have 2 cases of window period infection and 1 case of HCV and 1 of HIV in the last 10 years that we have been doing NAT. So we would have missed all these cases if we had not done that and just run an ELISA test and would have landed up infecting the patients. This is our equipment, which I proudly display in all my talks. NAT yield in India is high, probably due to high prevalence, and it meets, therefore, the need to implement NAT in India. The major barrier definitely being the high cost and the technical expertise in most blood centers. NAT could detect both HIV, hepatitis B, and hepatitis C cases in blood donor samples that were undetected by serological tests, and it could also interdict a large number of infected transfusions, thus helping provide safe blood unit. Now, following the importance, coming to importance of leukocyte-reduced red blood cells or leukocyte-reduced products. We all know that a Paxil unit contains around 2 to 10 raised to 9 to 5 to 10 raised to 9 leukocytes per unit. Now, when you say a leukocyte-reduced unit, as per the US standards, we need the unit having WBCs less than 5 into 10 raised to 6, and as per the UK, it is 1 into 10 raised to 6. Why do we need to reduce leukocytes? Because it could cause the most common non-hemolytic febrile transfusion reactions, the fever that develops because of the cytokines that released from the WBCs, HLA alloimmunization leading to HLA antibodies and platelet refractoriness that we very often face in patients who are dependent on platelets, transmission of leukotropic viruses like cytomegalovirus, Epstein-Barr virus, and HDLV1, transfusion-related graft versus host disease, transfusion-related acute lung injury, and transfusion-related immunomodulation or immunosuppression. Very often what we see is use of these leukocyte filters at bedside. It does give you a leukocyte depletion, but the problem with these is when blood is stored at the refrigerated temperatures, leukocytes fragment off, cytokines are released, so you do not have the non-hemolytic febrile transfusion reactions being controlled. Besides, the fragmented leukocytes are not effectively filtered as effectively when you do a leukocyte filtration at the processing stage. So it's fresh blood that is leukofiltered. And besides, you have an opportunity to do a quality control on the product and ensure that the product has WBCs less than what is required. When do we need leukocyte-reduced RBCs or blood? All multi-transfused patients, leukemia patients or plastic anemias, immunosuppressed individuals, patients to prevent recurrent febrile non-hemolytic transfusion reactions, prevention or delay of primary alloimmunization to HLA antigens, and prevention of CMV transmission for at-risk individuals. Now, coming to the quality control part, before releasing any blood bag, all blood centers would definitely verify the blood donor group, RH typing, confirm the RH negative by doing a weekly test, antibody screening, which is not done by all blood centers. All units need to be screened for irregular antibodies, and the basic screening for all the tests, VDL, HPS, HCV, and HIV, before releasing the blood bag. As a pre-transfusion testing, I think most of them do just a blood typing and cross-matching. It is necessary to screen the patients for irregular antibodies because we don't only deal with an ABO, we deal with multiple other blood groups, and alloimmunization is a known risk. So if you identify an antibody, if you detect an antibody, you need to identify the antibody and definitely give an antigen negative blood to the patient. TRALI is another risk that we do often face. And besides leukodepletion, one step that has helped us in mitigating TRALI is use of only male donor plasma in transfusion, which is a mandate across the globe. In India, we still do not use it as a uniform policy. But all females, especially multiparous or transfused female, plasma is not used for transfusion, at least at our center, so that we reduce the risk of TRALI because they are the ones who carry anti-HLA antibodies and anti-neutrophil antibodies. These plasmas are forwarded for fractionation at our center. Coming to the blood center, what do you do at the bedside to reduce the risk for transfusion? Employ specimen and patient identification parameters. Across the globe, it is known that an ABO hemolytic transfusion reaction is because of a clerical error, be it at the bedside, be it at the blood bank. So definitely or follow a tool identification policy to avoid a clerical risk. Okay. Definitely use an informed consent policy in this era and time. Ensure that the patient is aware of the risk associated with transfusion. Follow proper patient blood management protocols during transfusion. Use the right blood for the right patient. Report all transfusion reactions to the blood bank. Very often we see is fever, rash, chalo, let's manage it. But that would help the blood bank to at least give you the next product which would reduce the risk. So we need to know the reactions. Probably it's an allergic reaction. We would give you a plasma depleted product the next time to ensure that the patient does not go through a similar allergic reaction. Okay. Use alternative transfusions where possible. Safest transfusion is the one that you do not give. The best strategies, the best methods can only near the risk of transfusion to zero, but you do not have a zero risk transfusion supply even to date. Okay, so blood transfusions can be mitigated, but not eliminated. Therefore, as a warning, do not pull the transfusion trigger. Very unfortunate that being a blood bank, I have to say it, but use your correct patient assessment and clinical judgment before ordering a unit of blood and transfusing it. Thank you.
Thank you, Dr. Joyce, for the lecture. Any question from the audience? Are we having leukodepleted
Others 100%.
all
100%. At source.
What is the cost that comes for that and without that?
It is as per the regulatory authorities. You can add just to the 1,200 per unit. So and that you divide in your 3 products. So it is 700 addition for your paxils, remaining on your packed plasma and platelets. It's a regulatory requirement.
It's worth asking that testing always for all our patients. It should be the point.
Yeah, it definitely, we have learned it because incidents,
Or
it
or
opened
the
eyes.
parents don't follow that.
No, it is not a mandate, so you don't need to do it. The risk is very high in India for the upper hepatitis. We would have definitely used it to be, even in spite of using a fourth generation, the best immunization system, it hasn't been properly.
People ordering blood left, right, and center for our patients. Okay, thank you so much.
I mean, what is clear from your lecture, Dr. Joyce, is that, I mean, that testing, though it is not mandate, but it is mandatory.
No, it is mandatory, especially if I've seen my last 10-year experience, probably HIV and HCV may not be high if you're using a good basic screening method, but hepatitis B is a definite risk for the next few years. There are a lot of occult hepatitis B that even the donors do not know they have.
And thank you, I would vouch for Dr. Joyce, actually, she's our backbone of our hematology services. And I have never heard no from her, even in the middle of the night, when we need a factor. She said, okay, we'll arrange for it, we'll do this thing, we'll do something. And I'm really happy to have you okay. Thank you. Dr. That will also.
That we know that NAT testing is so much helpful, but at national level, if you don't push, the government hospitals will never get. So that issue, how would you address for the
At
government?
least in Maharashtra, there has been a take wherein we're planning to do a center wherein all the government could pool at a center. There were talks, but it's still at the top level. So we're trying to push it that push. Yeah, but it's still not happened. Unfortunately, it's not happened.
I don't know, like, how you all can support of the blood bank.
But you know, what I say is, at least not an act, we do not even do a proper basic screening. ELISAs,
Seniors, many of the seniors, they say that it is not cost effective when you do at a mass screening level, and that is why it doesn't get implemented.
cost would come down with the companies, there is more of people who are using it. Now the costs are high, we could bear the cost, but my manager is to sit on my head. But, yes, probably if everybody we could talk to the companies and bring it out.
Cost effectiveness is very relative, when we talk about it. I mean, one patient affected by that kind is like lifelong gone, and we have to give the whole medical care, the medicines and everything. So I don't know what is cost effectiveness in these kind of issues. Thank you so much.
For our next section, I will now like to call upon our next chairpersons. We have Dr. Gokul and Dr. Hiran Bhatter, who is a consultant internal medicine at Sir Richard Reliance Foundation Hospital. And we also have Sir Dr. Adam, who will be chairing this session as well. Requesting Dr. Dheeraj to introduce our next speaker.
After this excellent lecture by Dr. Joyce ma'am about the quality and of course plan, we have another interesting topic. Dr. I just introduced the speaker, Dr. Nidhi Mehta is a consultant and head transfusion medicine at Nanavati Max Super Specialty Hospital. She's a leading expert in transfusion medicine with extensive experience in complex transfusion support for patients with hematology and oncology disorders. She currently heads the Department of Transfusion Medicine at Nanavati Super Specialty Hospital. Her interests lie in hematology, tape transfusion practices, red cell alloimmunization, which we are going to hear, and implementing patient-centric transfusion strategies. She is actively involved in policy making, education, and quality improvement initiatives in transfusion services.
Thank you so much. Thank you, Dr. Shweta, for having me here. And it's always a pleasure to be amongst pediatricians, as I've worked at CTC PHO BMT Center for last 5 years, and dealing with thalassemia and sickle cell anemia had become very close to my heart. Dealing with nearly 300 transplants, harvesting for them, cryopreservation was really, really interesting experience. So today is HIV Vaccine Awareness Day. So as we say that no blood is zero risk, along with hepatitis, we may have HIV, and listening to Dr. M.B. Agarwal, sir, sustainability would come if we have all such kind of vaccines. So coming to my topic for today, so the plan of the talk would be like, I will talk about some basics of red cell serology, pathophysiology of alloimmunization, clinical implications, transfusion related challenges, Alloimmunization in Indian thalassemia patient. I will talk about certain studies, how to plan transfusions, antigen matching protocols, what could be done, new approaches, and key learning messages. So basics of red cell serology, we know all the blood group antigens are there on the red cell membranes. We usually know of blood groups, what we do it in day-to-day practice, that is ABO and RH. But that is much more than that. ISBT Working Party maintains the full library of blood groups. So till October 2024, 47 blood group systems had been identified, comprising of 366 antigens, and they are determined by 52 genes. So ABO blood group system, of course, it is the commonest in day-to-day practice. It is of clinical importance because we match just the ABO blood groups, and any mismatch can lead to life-threatening transfusions, and it can trigger complement-mediated hemolysis. RH blood group system is also of highly importance because the D antigen is highly immunogenic. So it comprises of not only one D antigen, it has 5 antigens, capital C, small c, capital E, small e. And absence of capital D is represented as D antigen. So actually small d is no antigen. There are other minor blood group systems, Kel, Kit, Duffy, MNS, Lutheran, which appear minor. They are called minor, but they may have a major impact in transfusion. Coming to RBCA antibodies, allo antibodies, they are typically IgG warm reacting, and they're detected with IAT. Patients may develop autoantibodies as well, which will be detected by a direct Holmes test. There's a pictorial presentation. I would not go into the details. So these are the 47 blood group systems, which is available on the ISBT website. Coming to pathophysiology of red cell alloimmunization, how does it happen? So it is basically adaptive immune response. We all know with the lessons in immunology, there is innate immunity and adaptive immunity. So it is to the point immunity to the antigen which comes and exposes. So patient, if he lacks certain antigen as is transfused with a donor who has that antigen, will be identified as foreign, and the antigen presenting cells who possess RBC antigens will activate the helper T cells and B cells, leading to production of alloantibodies. So it's a classic adaptive immune response to a non-self antigen. Influencing factors could be many: genetic, HLA immune response, recipient immune status can modulate the response. Repeated transfusions can increase the cumulative risk of alloimmunization. Transfusion-related immune modulation may sometimes induce tolerance, and the age at first transfusion may impact that. If the starting transfusion is at an early age, patient may have tolerance, but if it starts at the later age, it may cause higher incidences of alloimmunization. Does the alloantibody persist? It may, if once formed, but up to 70% of alloantibodies may go undetected later if they are not stimulated. So if the patient is being given antigen-negative blood, the antibody will not surface. But if unknowingly, without the screening, blood is given, it may increase. So usually memory B cells remain, and re-exposure to the antigen can elicit a rapid anamnestic response, which is highly pronounced. Clinical implications are hemolytic transfusion reactions. In extreme cases, the HB will not increase up to the mark which is required. Delayed HTRs can happen wherein rapid drop of hemoglobins, jaundice, fever, difficulty in finding compatible blood. Until unless the antibody is identified, it is very difficult to find the antigen-negative blood. If the thalassemia patients develop 2 antibodies, suppose capital E and capital K, so giving a capital E and capital K antigen-negative blood becomes a too much hassle. So it's finding the needle in the haystack for compatible units, and this can delay life-saving transfusions. Transfusion inefficacy, as I said, the HB will not increase up to the desired levels, what we need. Clinical management complexities, we obviously need specialized transfusion support. Workups are required, but as Dr. Joyce already mentioned, that leave aside the antigen typing or 3-cell panel screening, the simple screening of the patient is also not done. That's why we miss on the antibodies. Alternative therapies to this would be immunosuppressive therapies, which clinicians may be practicing splenectomies, though it is not the treatment of choice now. So the challenges what are faced, technical, logistical, administrators, and who would better know than the parent of a thalassemia patient? Availability to timely access of blood, safe blood, that is TTI or adverse transfusion reactions which may happen, and alloimmunization. So cost of the screening panels is too high. For the identification, it is too high. So challenges are limited antigen matching and donor pool constraints. Routine practice gap is as we are not doing the full antigen profile prior to starting the transfusion. Donors are only typed for ABORH. Extended typing for minor antigen is not done typically. So if screening is not done, antigen typing comes much later than that. So when is the minor antigen testing done? It is usually a reactive response. If the blood is incompatible, then we go there and we try to do. But if the patient is already transfused, it is not possible to perform the testing. And we obviously don't have a donor phenotype database. So donor pool limitations is a huge challenge in our country. And if patients are rare phenotype, which is negative for high frequency antigen like small e or small k, and if patient is exposed to a person having this, then the life is really miserable to find that unit. So this calls for better inventory management and rare donor pool registries for the country. Resource constraints, whenever the factor comes to, upgrade the services, like, upgrade NAT, any patient would like the best of the stent to be placed in his heart, but getting the best of the blood, spending that extra 1,200 rupees or extra 500 rupees for a extended phenotype match hurts. So it's really the time where clinicians should be asking for that instead than that we explain it to the patients. So alloimmunization in Indian perspective. Most single center studies, they show that the allo antibody prevalence is between 3 to 10%, but single center studies have given the percentages up to 20%. Common antibodies, of course, of RH system. So as I said, it's not only capital E, it is CCEE. The KEL system is another major contributor which comes in. Implication of antigen frequency is much if the E antigen is present in only 20% Indian donors. Obviously, the E negative patient has a high chance of exposure. So understanding the frequencies is very, very important. This is a study which was done at Ludhiana in 2024. It was published, wherein in the thalassemia patients, the most common antibodies identified were highest were KEL, 7.1%, followed by capital NTD and capital NTE, 2.85%, and small c and capital C of 1.42%. So patients with thalassemia should be typed before starting the transfusion, and that can only feasible and possible if the patient is referred to a bigger center. This was another meta-analysis done by Dr. Shami Shastri from KMC Manipal, wherein it was a similar study which showed that how the prevalence of antibodies is there. So rate of alloimmunization was 0.5 per 100 patients tested for antibodies, but 4.8% per 100 patients receiving transfusion. So capital E and C matched blood is very, very important. So this was a study done in South and published in 2024, which talks about if we have a donor pool tested and ready with these minimum RHKL antigens, it would be easy for us to provide antigen negative blood. This was another study done by Dr. Our own Dr. Swati Kulkarni, who had tested 500 O regular blood group donors, and she had found the prevalence of antigens in the donors and kept the database ready of 193 donors matching for RH, Duffy, KEL, KID, and was prepared for 15 alloimmunized patients to make their life easy. So transfusion planning, as I said, the new patient with thalassemia who we know would be transfusion dependent, the pre-transfusion prior to the transfusion, RHKL typing should be done. Ideally, a genotypic screening would be the choice, but even if it is not done, even the RHKL typing, phenotyping would work. So if the antibody screen is negative, the routine transfusion can be done and RHKL matched blood should be given. If the antibody is positive, the antigen negative blood has to be given. And for future prevention, extended match always is required. So antigen matching protocols could be extended phenotypic and genotypic matching. So phenotype is a target a predictable set of antigens, and we do that. Challenges is it may strain the availability of blood. It may help it may impact the inventory management. So standard of care is to have a extended antigen matching. So here is the formula how to calculate how many units have to be screened. So if a patient has formed antibodies against specific antigens, the number of units required to be screened to find a compatible unit is calculated using this basic probability formula, which is like number of units required and probability of compatibility. So probability of compatibility is product of frequency of antigen negative donors for each antigen if the patient has developed antibodies against it. And if the antigen frequency in the population is F, then the frequency of antigen negative blood body is 1 minus F. So here is an example. So suppose if the patient has NTK against KEL antigen, so KEL antigen prevalence is approximately 9% in the population. So antigen negative frequency is equal to 1 is minus 0.09, that's 0.91%. And we need two compatible units. So this would be the formula, units to screen 2 divided by 0.91. So approximately 3 units have to be screened to find that compatible unit. And if the patient has two antibodies, that is capital E and small c, against the capital E and small c antigen, so frequency of E in donor population is 30% and frequency of C is 80%. So if we multiply that, the factor comes as 0.14. We need 2 units. So divided by 0.14, we will have to screen 15 units to find a matched blood. So role of genotyping. So if patient is already multi-transfused, phenotype results would not be clear. There would be mixed field reactions. So in those cases, genotyping is always better. So it overcomes this by identifying the patient's genetic antigen profile from DNA. And if the patient is, so it can also identify if a patient lacks high frequency antigen, flagging the need for special donor units early. So there was a study done in Iran wherein they had studied the phenotypic and genotypic matches. And it was very clearly evident that there was a difference between the phenotype and genotyping. So there was complete accordance with genotyping studies, but phenotypic and genotypic were not matching. So this is more reliable. New approaches, sir has already spoken, so I would not touch on that. So the key learning messages from my talk is regular breast transfusion remains the mainstay of the management of thalassemia patients. It is important to ensure that blood inventory for patient care is sufficient and accessible, essential to address the unmet needs of transfusion, collaborative approach and mitigating the gaps by defining priorities. All stakeholders should get involved in the policy making, and feedback from patients and relatives should be considered to tailor the future actions. So this was a recent study published in which spoke about to raise the community awareness, regular training of healthcare workers, proper utilization of available resources are essential to ensure safe blood, and access to the new treatments at affordable cost is very, very important to reduce the burden on the thalassemia patients and burden on the blood banks to provide sustainability to thalassemia patients. This is the hospital where I work. Thank you so much for patient listening. We are hosting the 20th Annual ATOM Congress and 5th Joint Meeting of ATOM and AABB. AABB is Advanced Association of Blood and Biotherapies. So you are most welcome to attend the event. It is on 14th and 15th November, and the venue is Aurika Sky City, Mumbai. Thank you.
Talk is some real life example after this talk. Earlier thing which Dr. Joyce madam pointed out, having this the sacred blood is which is not transfused. So I'll just tell you this 4 years back, we had one young girl, newly married, had gone to Leh Ladakh and come like 6 months ago, never been diagnosed of any issue. And she came because she was feeling weak. HB was around 4. Came in the night in the emergency department, we transfused. And after that, we had a nightmare because she went discharged after that. We did the basic workup like iron studies very, very low and thalassemia intermediate later on, it's minor basically. and she came back after some around 5 days back with hemoglobin of 3. And then we had a hell of a thing, because then we got history in dengue 5 years ago. She was transfused. So we were surprised when there's hemo concentration, why a patient needs blood. So she was living a happy life with hemoglobin of 4 or 5, whatever it is. And then maybe a previous transfusion memory cells were there, and then that triggered alloimmunization, and the thing was never we could build up. We were always avoiding transfusion, but day by day the HP was dropping to as low as 1, 1.2, 1.42 in the ICU. We did everything, rituximab, plasmapheresis, first IVIG, then we couldn't do splenectomy, no surgeon were ready. We were ready to give fitness, but with hemoglobin 1, nobody was ready to touch. So we had to do embolization of the spleen, but she could not make it. So I feel the importance of Dr. Joyce's madam lecture and this, that we should have extended screening and all this thing. Inadvertently, we caused alloimmunization or maybe awakening of the memory cells, and then it was a nightmare. Okay, you have any questions from the audience?
Thank you so much.
Thank you.
To our chairpersons, and also thank you, Dr. Modi. I now call upon our next chairperson for our next session. We have Dr. Somesh Lala, who is a senior radiologist at Sir H.N. Reliance Foundation Hospital, who will be chairing this session. Let Dr. Somesh to introduce our next speaker.
So next speaker is Dr. Nidhi Bansali, and as you can see, she's a fellow in cardiothoracic imaging, and she's a consultant radiologist at Shankarya Imaging Center, Mumbai.
Very good afternoon to everyone. It's truly a pleasure to be here among colleagues, seniors, and stalwarts who play such a vital role in the early diagnosis and lifelong care of children with hemoglobinopathies. And I really thank Dr. Shweta Bansal ma'am for inviting me here today. In this session, I hope to highlight the importance of imaging, especially MRI, in the management of these patients. So our role generally starts where yours continues, that is in the monitoring and as guidance of chelation therapy, especially in patients who are on transfusion-dependent anemias. So just at the outset, if I can have a quick show of hands, how many of you here actually use MRI in your practice for detecting iron overload in these patients? Right. So it's clearly not the majority, and I really hope to drive in the point today, and hopefully more of us can actually be incorporating this in our long-term management for these patients. So we all know that iron deposition after repeated blood transfusions can practically happen in every organ and gland of the body. Yeah. So MRI is really a game changer here because it can help us to detect this iron deposition, which occurs in various organs at a very early stage before it is actually clinically apparent. And that is where it helps us in preventing end organ complications and irreversible damage to the tissues because of the deposited iron. And we'll see how we do that. So based on the natural history that occurs, there is years and years of clinically silent iron accumulation, which predominantly the main organ of concern here is the heart, because as Dr. M.B. Agarwal sir also pointed out, the main cause of morbidity and mortality even today remains heart failure. And we increasingly see thalassemics surviving into their 30s and 40s, but then succumbing to irreversible heart failure. So what with MRI, what we try to do is pick up this iron deposition at a stage where it can be corrected, and so the patient does not land up with irreversible heart damage. So MRI basically will help us to pick up this iron accumulation at the clinically silent stage before irreversible cellular toxicity or iron overload cardiomyopathy occurs. And in fact, not just iron deposition, it will also help us to assess the cardiac function in the same setting. And we can actually detect early dysfunction, which is reversible, potentially reversible, before there is irreversible heart failure. And when we compare this with other methods to screen iron overload, such as estimation of serum ferritin levels or doing liver biopsies, MRI has the advantage of being non-invasive, radiation-free, and more specific as well as sensitive, because serum ferritin is a great tool to give us an overall sense of what's happening, but MRI is tissue and organ specific. So we know exactly which organ is getting most of the iron deposition and how much there is. So how do we do this? So basically we have a tool which is called as T2 star, which is a sequence in MRI, which tells us how much iron is deposited in any particular organ. So what is T2 star? Without delving into the details of physics, because we are not a radiology audience here, basically this is an estimate. So whenever iron gets deposited in a tissue, iron behaves like a magnet, and MRI is a magnetic field. So what happens is the tissue which has accumulated excess iron is going to show different type of decay in the magnetic field versus a normal tissue. And what we are trying to measure here is the difference between a normal tissue versus a tissue which has iron and is hence behaving differently with a faster rate of decay of magnetization. And this difference is measured in terms of the T2 star value, is what we call. So this is just to show you that there have been several studies over the years which have highlighted that this T2 star value, which we obtained from our MRI study, correlates very well with the incidence of heart failure in these patients. So as you can see here in the graph, when the T2 star values, which is on the x-axis, they actually fall below 20 milliseconds, you see a much higher incidence of heart failure in the patients. So there is good correlation between the two. Therefore, if you see an elevated T2 star before heart failure is actually developed, this is a very good predictor that this patient is at a high risk for developing heart failure. And so you would want to maybe intensify the cardiology evaluation and monitoring. Also, there is a good correlation of T2 star values with the incidence of cardiac events apart from heart failure, so which may be arrhythmias or any other events. Again, there has been a study which was performed in the UK, which showed that there was significant improvement in survival of the patients who underwent regular routine MRI screening and iron overload assessment versus those that didn't. And another thing that I would like to highlight here is that very often we don't, those who are not routinely referring patients for MRI evaluation. So you have two types of magnets. You have a 1.5 Tesla versus a 3 Tesla MRI. And the studies that have been performed across the world have generally been on 1.5 Tesla magnets because those are more widely available. However, we at our center at Jankharia Imaging, we have a 3 Tesla magnet and we routinely perform scans for these patients, on our 3 Tesla magnet. And there has been a good correlation between the 1.5 and 3 Tesla values as well. So you could refer your patients to either centers, like either whether the center is a 1.5 or a 3 Tesla, it does not matter as long as you're doing this regularly and you're following up the patient at the same place on the same machine. It gives you good reliability. So how do we actually do it? So what do? We first start with anatomic assessment because that also forms an integral part of this. So we obtain actual images of the whole chest, which gives us an idea about whether there is anything grossly wrong in the anatomy. If I can just use the pointer. Yeah. Yeah. So here what you can see is these paravertebral, this is the heart, this is the vertebra behind, and these are paravertebral symmetric soft tissue masses, which would represent extramedullary hematopoiesis, which is very often seen in these patients. So we look for that. We could also look for any other additional findings, such as whether there is any lymph node or any other secondary complications that the patient has due to the underlying disease. So we evaluate the overall anatomy of the heart, the mediastinum, as well as the abdomen, followed by functional assessment. So we obtain cine images of the heart. Yeah. So basically, based on the cine images, we will get a good idea of what is the LV function, the RV function, and whether all of the volumes and parameters are normal or not. And based on this, we will be able to pick up any early dysfunction if it has occurred. Unfortunately, these videos aren't playing well here. Anyways. So then we move on to acquisition of a multi-echo gradient echo T2 star sequence. This was the sequence I was talking about, which is the mainstay of evaluating whether there is iron overload or not. So we start with the heart. Okay, what you see here is a mid-ventricular slice, which is showing us the left ventricle here and the right ventricle here. And we image the same slice at subsequently increasing echo times. And that basically tells us, so what we need to look at is if you trace this left ventricular myocardium from the first echo time to the last, you see that the signal or the gray, the intensity of the gray signal is near about the same. It does not change much. That means that there is no significant iron deposition. Whereas if there was iron deposition, we would see a consistent darkening of the signal or a blackening of the signal. I will show that in the subsequent cases as well. So this is how we image the heart. And this is followed by, placing a region of interest, which is manually selected within the interventricular septum. And the value obtained from this gives us the T2 star value. And we always draw this in the septum because that is what correlates best with whole heart iron. So just one region of interest in the septum can help us in getting an idea about the diffuse involvement of the myocardium. And this is the reference ranges that we use. So generally, when the T2 star values are above 20 milliseconds, it corresponds to no clinically significant iron overload. Whereas as they fall down, there is progressive increase in the grade of iron deposition, and less than 8 milliseconds would basically indicate severe iron deposition. And how this translates into management recommendations is that generally when the T2 star values fall below 20, it would indicate that chelation therapy needs to be started if not already done. And when they worsen further, you want to possibly change, adjust, or intensify chelation therapy accordingly. So T2 star is not the only technique in town. We also perform something which is called as native T1 mapping, which is another parameter which helps us with tissue characterization of the myocardium. And this also correlates very well with the T2 star values. But basically, normal myocardium has a native T1, which is in the range of 1200 to 1300. And when we see that falling down, that also is another parameter which tells us that there is iron overload happening in the heart. So after the heart, we go on and image the liver, which is the next important organ. And again, we obtain a single slice of the liver with progressively increasing echo times. And we look for the change in signal intensity over these echoes that have been obtained. And if you trace the liver from the first to the last slice, you can see how the gray signal is actually becoming darker with each progressive increasing echo time. And that indicates that there is iron deposition in the liver. And this, how much darkening or how much the signal will change will again depend on how much iron is there in the liver. Right? So again, we would draw an ROI, which is a region of interest within the liver parenchyma, and obtain the T2 star values, which are then quantified. There's a separate scale for grading the T2 star in the liver, and this is how it goes. So over 6.3 milliseconds is generally a normal T2 star value for the liver parenchyma, and when it falls below 1.4, you would call it as severe. And again, this helps to guide chelation therapy, just like the heart. Beyond heart and liver, we also image pancreas and pituitary. So again, with the same logic, we obtain a multi-echo gradient echo sequence for the pancreas. Here, what you see in this region here, this is the pancreatic head. All right. And if I trace it from the first to the last echo, you would see that the intensity of the signal doesn't change much, which again goes to say that there is not iron, there's not much iron deposition happening there. And again, you would process it similarly, draw an ROI, obtain the T2 star values, and then grade them. The grading for the pancreas follows that for the heart. So after that, we go on and image the pituitary. We obtain a T1 sequence to look at the anatomy. Very often, these patients will have atrophic pituitary glands, and like it gives us an idea as to what is going on there. And then we again subject the pituitary to the gradient echo sequence, and this is where it is. And then you try and see how the signal changes over time. So you do a qualitative and then a quantitative assessment, draw an ROI, obtain your T2 star values. And in the pituitary, we don't have a grading scale yet because it's not done widely across the world. But what we do say is whether iron deposition is present or absent. Okay, based on, we follow the same scale as that for the heart. So above 20 milliseconds is generally absent, and less than 20 milliseconds, we would say that pituitary iron deposition is present. And we also corroborate this with the visual estimation looking at the subsequent echoes. So just some quick case scenarios. So this was a 30-year-old gentleman living with thalassemia major and clinically asymptomatic. And this is the, so this is the cine images, and that showed normal cardiac function, nothing wrong anatomically either. And in fact, this patient had been on regular blood transfusions since a very young age, but had also been on inconsistent chelation therapy with the serum ferritin level of approximately 700 nanograms per ml, which was not considered to be clinically alarming. However, when we performed the MRI, what we saw here was, if you see, this is the gradient echo sequence for the heart. And going from the first image here to the last image here, you can probably appreciate this linear area, which is showing subsequent darkening, which is not black in the first image, but it becomes black towards the end. And this was a very small area of early iron accumulation in the heart, which we could pick up on MR. And obviously, the ROIs also showed a reduced T2 star value below 20 milliseconds, which was corresponding to mild myocardial iron loading. And T1 native was also reduced. And then when we imaged the liver and the pancreas, what you see here is a very dark liver right from the first image itself. So not much potential to even become darker. So this is very severe iron loading. And if you focus on the pancreas in the second row here, you can see that it is becoming subsequently darker as the echo time progresses. And this corresponded to severe liver as well as pancreatic iron loading. So this really changed, or kind of was helpful in changing the management decisions here, because just based on the clinical aspect, probably nobody would have changed the chelation therapy for this patient. And also what we saw was the pituitary, if you see here, becomes subsequently darker. So that would correspond to presence of pituitary iron loading as well. Similarly, this is another patient you can see here. Yes, absolutely. Almost done. So this is another patient where you can see that there is subsequent darkening in the myocardium on the gradient echo sequence, again corresponding to moderate myocardial iron loading. And similarly, the liver, you can see the subsequent darkening in the pancreas as well. And both of them were moderate to severely loaded, with also loading in the pituitary. So I'll skip this case and I'll just highlight something else here, which is how follow-ups are important in these patients. So just one-time imaging is not that helpful, but when you do a regular follow-up, which is generally recommended once a year or at least once in 2 years, you see that how this patient from 2021, he went on to have improvement in iron loading in 2023, with again worsening in 2024. So there can be waxing and waning over time, and that helps to guide the appropriate chelation therapy in these patients. And also different organs can behave differently. So you may have improvement in one organ, but worsening in the other. And so MRI being very organ specific really helps to guide management here. And this is another patient, he had stable myocardial iron overload over a period of 2 years. But what we did see was that when he came back for a follow-up after 2 years, there was a visible reduction in the LV ejection fraction. So this is what I was talking about, early cardiac dysfunction, which can be picked up only on the MRI, and that can help the patient. So again here, this was a patient who had mild worsening of iron overloading over a period of 4 years, not very significant. But definitely when he came for follow-up here, we saw that there was RV dilatation, RA dilatation, and worsening right heart function. So both left and right ventricles can be affected, and we can pick up all of this on the MRI. So the limitations here would be that MRI does bear a higher cost as compared to other imaging modalities. There's limited availability and you require expertise in acquisition and interpretation. But by and large, it is a great technique and it plays a crucial role in early detection of iron overload, guiding management decisions. And also there is simultaneous assessment of multiple organs. And hopefully, if there is wider availability and application, it can, help to improve patient outcomes significantly. Thank you.
Thank you, Dr. Nidhi.
Yeah.
I forgot to mention that she has contributed a lot to capacity building and awareness programs and promoting the role of imaging and optimizing thalassemia care. Any questions for Dr. Nidhi?
How do you standardize the machine? Because at many places it has been asked that how do you standardize the machine and what standards you are using for the control of the.
Yes. So, as I said, most of the studies that have been conducted over the last 2 decades have been on 1.5 Tesla magnets. So there are very standardized values for that. And basically, if some place were to start afresh, like you are sending patients to a particular center and they have to start doing these scans, they would possibly scan a few normal controls initially, establish a normal range of values on their machine, and they should corroborate with the otherwise published values as well. And then once that is done, they would know that if a particular patient has iron over, whether it's falling in the normal range or it's elevated, etc. But the most crucial thing here is because of this variability between machine to machine and center to center, the follow-ups should be at the same place, ideally, if a patient is first referred. Yes.
So we do more than 100 patients every year.
Yes.
But then when we had to publish something about this, we always asked us to how the machine is standardized. So I had been asking this to Dr. Bhavin also.
Yeah.
But do you use any software? There is some software called as Scan, or you do multiple, or like how many CDC machine we keep on standardizing by doing normal routines. So do you have that every year you standardize the machine?
No, ma'am. We don't really need to do that actually. So only when the magnetic field changes, the values would change. But if the machine, the magnet remains the same over the years, we don't need to establish normal reference ranges every year. So it was established when the machine was started off, and that carries on through the years. And
1.5 better than 3 Tesla?
So 1.5 is considered to be better because, first of all, because as I said, most of the studies were conducted on 1.5. So the values are more widely established. And secondly, they say that there is lesser chance of having artifacts, so to say. But in our experience, we have never had a patient that, we had to refuse because of artifacts or anything of that sort. And what we do is we use a conversion factor and we give 1.5T equivalent values. So again, for publishing studies, etc., that works. So there is no clear benefit of doing it on a 1.5 Tesla versus a 3 Tesla.
Thank you, Dr. Nidhi. So,
I have this one question. First of all, how early do you want us to refer patients for initial screen? And secondly, if we send you for an initial screen, since MRI is very organ specific, which organs would you want us to screen first for iron?
Yeah. So generally, below 8 years of age, this has very less benefit because most of the iron accumulation and overloading occurs after that age. There is no published recommendation, but this is what is generally followed. Below 8 years of age, we do see some patients coming in for assessment, but it's by and large not supposed to be that helpful. Above the age of 8 years, there is definite benefit. And what we do is assessment of 4 organs: heart, liver, pancreas, and pituitary, as I showed. But at least the heart and liver needs to be assessed. That is the basic necessity. And pancreas and pituitary may be done if available. Because the main aim here is to prevent heart failure, to detect heart failure at an early stage. And also, the next most important complication is liver iron deposition, cirrhosis, parenchymal disease. So those are the things that we are trying to prevent. So those are the 2 main organs. Thank you.
When you said T2MI should be repeated every year, once a year or once in 2 years, I just wanted to know, do you provide counseling to the parents or the patients to the result of this T2MI to the experiment program?
No, sir. So as radiologists, we don't have that facility. Generally, the referring clinicians will be the ones counseling the patients and the parents regarding doing this. We just, sometimes patients do come to us and they tell us, please, explain what is the interpretation of this scan, and we then try and explain to them. But generally, the counseling part is done by the referring clinicians.
You don't have that.
No, sir. No.
Thank you, Dr.
Thank you.
Thank you.
Thank you very much, Dr. Midi, for this session. Thank you, Dr. Somesh. I request Dr. Somesh to chair the next session as well and introduce our next speaker.
So our next speaker is Dr. Rajni Krishnan. She's a senior consultant radiologist at our hospital. She is an accomplished radiologist with specialized expertise in neuroimaging and Doppler. And she leads initiatives in our department in integrating advanced imaging techniques for hemoglobinopathy care. And she has a keen interest in the role of PCD, which is transcranial Doppler, in sickle cell disease, and its implementation as a screening tool to prevent neuro complications. So over to you, Dr. Rajni.
Good afternoon. So today my topic, veering away from thalassemia and getting on to sickle cell, I'm going to speak about the role of transcranial Doppler in sickle cell disease. Now, exactly what is sickle cell? As most of you are aware, it is a hereditary condition. Because of that results in the formation of an abnormal hemoglobin. So it is a hemoglobinopathy, and this clinically manifests as a multisystem ischemic infarctive process and also results finally in hemolytic anemia. It occurs because there is a mutation in the gene coding of the beta chain of the hemoglobin molecule, which is called as HPS. Specifically, the valine is replaced by the glutamine at the 6th position. Basically, the structure of the red blood cell changes because of this. And the term sickle cell disease, it applies to all patients who have 2 abnormal beta chains. Because they have 2 of these chains, the resultant hemoglobin molecules form long polymers. These polymers make the shape of the cell sickle shape, that is elongated and rigid. These are then unable to pass smoothly through the flowing blood through small vessels specifically, which results in multiple vascular occlusions at multiple organs. Also, these abnormal cells are removed at an increased rate vis-a-vis the normal red blood cells, and that results ultimately in hemolytic anemias. Now, sickle cell disease is when they have 2 beta chains. If they have just 1 beta chain and 1 normal beta chain, then they are called as sickle cell trait, and usually these patients are asymptomatic throughout life. Those who have 1 HPS beta chain and 1 HBC beta chain are called as hemoglobin SC disease. Now, we are going to talk about sickle cell disease, that is those kids who are diagnosed and they have 2 abnormal beta chains. Cerebral manifestations specifically contribute very significantly to the overall morbidity of this disease process. And in the pediatric population especially, the most leading cause of stroke in sickle cell disease is sickle cell disease itself. So approximately 25% children who have sickle cell disease would expect to have a neurological event at some time or the other in their life, and it's usually in an earlier age. What exactly is a transcranial Doppler then?
Now, transcranial Doppler is a non-invasive process. It allows accurate, sensitive evaluation of the cerebral vessels, primarily for vasospasm. And there is no use of any contrast medium that is required. There is no ionizing radiation that is required. It is an ultrasound procedure, so it can be done at the bedside. You don't have to move an ICU patient to the ultrasound department. And it's also very cheap compared to the other processes. It's primarily based on two principles of physics. One is the Doppler principle and one is the Bernoulli principle. Doppler principle or the Doppler shift that we've read about when we were in school is defined as the change in the frequency of a sound wave that comes back when it is moving towards or away from an object. So you as a transducer are sending waves in, and different blood cells that are moving at different depths and at different levels away will send back waves at different levels. The frequency changes when it comes back, and that change in frequency is interpreted as the Doppler image that we get. For example, this is basically just what I said. And what is the Bernoulli principle? The Bernoulli principle states that there is an increase in the speed of fluid, which is accompanied by a decrease in pressure. That means if a fluid is flowing faster, it will have lesser pressure. That is the Bernoulli principle. The equation utilizes the assumption that is delineated in the law of conservation of energy. And this then calculates the pressure gradient between 2 points based on the velocity. The simplified Bernoulli equation, which is primarily of interest to us, it provides a way to estimate the pressure gradient across the valve or the stenotic segment based on the measured velocity of blood. Basically, if the stenosis is more severe, the difference in the velocity before and after it will be much higher. That is basically what this slide indicates. Okay. Now, there are multiple cerebral radiologic manifestations that we can see in a child of sickle cell disease. Primarily, what I will be focusing on is intracranial ICA stenosis and occlusion, which over time and multiple repeated episodes will result in moya moya. Resultant to that, distally, there can be cerebral atrophy. And it is primarily we are looking for chronic small vessel ischemic changes. Again, I'm repeating it. Stroke is one of the most deadly and disabling complications for children with sickle cell disease. And it primarily affects the medium-sized arteries, which in our case of interest is at the circle of Willis. As I'd said in my initial slide itself, that the sickled cells are abnormal and they tend to get stuck and cause occlusions, stenosis. And with that occlusion stenosis, you get collateral circulation. So it altogether is picked up by transcranial Doppler with much ease. Patients are at risk for ischemic as well as hemorrhagic strokes. Ischemic strokes are seen commonly in really small children and in adults over the age of 30. And hemorrhagic strokes more often are seen in the young adult patients. Sickle cell is known to cause childhood stroke in patients up to 11% of patients, and the maximum peak that we see is between 2 to 9 years of age. Once a child has developed stroke once, the subsequent risk of developing it within 3 years, that means having a second episode, is as high as 90%. Now, how is this study performed? We are going to do it on children for whom the fontanelles have already fused. So what is the point of doing an ultrasound? All of us know that ultrasound doesn't pass through bone. So then why do we say that this is still useful? What we do is we use a very low frequency probe. Unlike the normal ultrasound or the normal Doppler, we use a really low frequency probe about 2 megahertz, which is ideally what is used by the cardiologists. That or lower than that. Okay. This allows the beam to pass through thin plates of bone. So you can see inside, but it is obviously not as good as with a normal adult image that you would get. And where do you do it from? Now, because the bone is quite thick, there are some windows which are preferred. These are the 4 windows that can be used. The first one is the transtemporal one, where we go through the squamous plate of the temporal. It's above the tragus. You just go up and you get the thin plate of bone through which the ultrasound beam can pass. The second one is the transorbital, where you put it close the eye of the patient, put it at the roof of the orbit, and through the optic nerve canal, you will see into the brain. The submandibular is at the angle of the mandible. Basically, you will look for the terminal ICA just before it goes into the carotid sheath, into the carotid foramen. And finally, suboccipital from behind. what are the vessels that you pick up? From the transtemporal, you will see the terminal ICA just before it bifurcates. You will see the A1 of ACA, M1 of MCA, and P1 of PCA. From the transorbital, you're looking through along the optic nerve. You will see the carotid C4 and the ophthalmic artery. From the submandibular, as I said before, you're looking at the terminal ICA just before it enters the skull base. And from the suboccipital, you will see the basilar and vertebral. Now, this is all in theory. In practice, what we primarily use is the transtemporal. Okay, and transtemporal has to be done from both sides. You have to look at the right side from the right, you have to look at the left side from the left. This is a textbook image of how the circle of Willis looks on a transcranial Doppler. And this is another textbook image of how the MCA looks on a transcranial Doppler. And these are perfect images with wonderful color and no aliasing and nothing. In actual practice, this is how we get images because it is difficult to perform. The child is not cooperative, the child is moving, there is a lot of noise, there's a lot of hangama around the baby. But it is still a very doable thing, which is my intention of putting these slides. And in spite of doing it in smaller kids, we can still get images like this. That was the MCA, this is the ACA, this is the ICA. Okay. Now, when should we start this? Once a child is diagnosed as a case of sickle cell disease, it is better to always start the screening at the age of 2 years. Because if you remember my previous slide, I had said that the risk of stroke is the highest between 2 to 9. So it's better to start at 2 even though the child is asymptomatic and clinically normal. The screening should ideally be continued at least till the age of 16. And because we expect that the child who comes to us is going to be a small, normal 2-year-old in that deadly toddler 2 stage, try to keep the initial examination as comforting, as calm, as enjoyable for the child as is possible. Maintain a regular result sheet where you keep a baseline and then you follow it every year to see how the velocities are changing. Okay, this will give you an idea whether the graph is being stable, whether it is rising up, whether it is falling down, and when you need to intervene. How do you interpret these images? If you go back to this, if you notice that there is a green arrow that I've marked, which is the peak systolic velocity of the flowing blood that is obtained, in this case, in the right ICA. Okay. Now, normal velocity, acceptable velocities, what we label as normal is when the peak systolic velocity is less than 170 centimeters per second. Higher than this, if it is 170 to 200, that is called conditional. And if it is more than 200, that is called abnormal. Now, it is not as easy to do as I'm talking about it now. So if you get one abnormal reading, it is not good to directly go and label it as conditional. Repeat it on the other side. Repeat it at least 3 times so you know that you're actually getting abnormal levels. And then label it as either normal, conditional, or abnormal. And how does that imply for a pediatrician? If it is a normal study, that means if the peak systolic velocity is less than 170 centimeters per second, nothing really needs to be done except for your regular annual follow-up. But if it is conditional, if you're getting it at a peak systolic velocity between 170 to 200, it is better to repeat the study after 3 to 4 months. These patients need not always be clinically presenting. They can be just normal. It is still better to repeat it after 3 to 4 months and use the graph to see whether it is rising, whether it is falling, whether it is static, and then decide what needs to be done. But if it is more than 200, that means if it is definitely abnormal, then you need to start some other therapy. So if it is more than 200, it is on me to call the pediatrician and inform them that you have sent this patient to me and he has an abnormal TCD reading. So please look into it. Okay. Abnormal TCDs are very strongly associated with vasculopathies and a markedly increased stroke risk. And those with more than 200, that is abnormal values, they have a significant increased risk of stroke and definitely benefit from transfusion therapies. So it's a short talk. The basic take-home message is that TCD is actually a very easily available. Ultrasound is, as you know, very widely available. Cardiac probes are also available in almost all centers where they do ultrasound, which is primarily what we use to do a TCD. So it's not a very difficult mechanical or a instrument kind of a thing to ask for. It is painless. There is no radiation. It is, if you can develop a rapport with the child will not have a problem coming back to you. So it's basically cheap, easily available, painless, with no radiation risk involved. You should start the screening as early as 2 years and preferably continue it every year at least once till the child is 16. And if it is an abnormal report, that is, if the PSV is more than 200, please definitely start some other treatment to aid the child. Also. Thank you.
Any questions for Dr. Rajni?
Okay, Rashmi, what you have said in your this thing last take-home message. I mean, we've been struggling to get the PCDs done for our patients
Same here.
also. But you're saying it is very easy.
It's
to
actually
do.
very easy.
So what's the gap over here?
Want me to answer that?
Yeah.
Okay, so, Dr. Shweta, firstly, we have a machine in our hospital for TCD. Like you said, we need a low frequency probe. We have one machine in our hospital which has that particular probe. There are 2-3 limitations of transferring Doppler. Number one, it is very operator dependent. So you've got to get that angle correct, and you got to first identify the bony landmark and then get that angle to get that the beautiful circle of village she's talking about. It doesn't come that easily. But we can see the MCA, we can always get the MCA, we sometimes get the ACA also. So it's not that we can't do it. Firstly, the number of cases we get are few and far between. So, we don't have that. We lose practice every time. You will send one patient, the next patient will come after 2 months. So, because of that, it's a little more challenging for us. It's not an easy Doppler that way. But once you get the bony landmark and once you get that angle correct, it's not difficult at all. That's one. Second is that in the ICU, you don't always get the position of the patient correctly. Like normally we're not doing so much of sickle cell work, we're doing more for vasospasm for the neurology cases we do. Patient may not give you the exact position sometimes, they keep moving. So that's a challenge also in PCD. And third, sometimes, not in kids, but more in adults, the thickness of the bone can make a difference in getting the correct angle to get the PCD. But I tell you that if we practice, it's not difficult at all. We do cases, like she said, she showed you an
See,
image.
with a low frequency probe, it will pass through the squamous temple.
Yeah.
That is a thin bone. The problem is that
Not
if it's a
on the
sick
kid.
child,
Yeah.
the child is crying anyways. That is why I said in my slide that the first time the child comes to you, if you send the child to us and the child is 2, and the child comes and realizes it's not really such a big thing, they're putting a nice cold jelly and they're just letting me see. Then if the child realizes, children are not stupid. Once they realize that the doctor is not going to do something that's going to torture me and it's just a normal go get the test done and come, they will sit. But getting over that hurdle, making that relation with the child and letting them cooperate with you that is a task.
So
And it has to be repeated from both sides. You can't do it just on one side. You have to look at the right-sided vessels through the right squamous plate. You have to look at the left-sided ones through the left side.
You don't have, all our machines don't have a TCD probe.
But it is available.
It is available, we have it in our hospital. Because obviously the number of cases we are doing are very little.
Yes.
So it looks like a 2D echo probe because you need a small footprint and you need a low frequency. Because it's like, we get one case in a month to do. So, it's not part of our volume work. You know what I'm saying? So when we buy machines, we don't buy TCD probes. But our hospital has got two machines we've got, which can do TCD. We have settings also. So we can get the work done. That's not a problem. And we do actually do it. We go to the ICU and do it.
So those are from our hospital only.
This case she showed.
Those images are our hospital only.
Yeah. So MCA is relatively easy to get.
MCA, ICA is easy. ACA becomes a slight issue to get.
Yeah.
But that also, if you get the right angle, it comes.
So, but if you take baseline MCA also, because once the occlusion takes place, the velocities will change in the MCA. So we have an M1 and N2 segment. We can trace it, we can get the velocity, and we can document.
And see, if you could document MCA, AC, and PCA, it just adds to you. But the presumption also is that if one vessel is affected, that is also enough for you to start the treatment. Just because one is affected and maybe the other two are not, does not really mean that the treatment is going to change so much. One is still affected.
If we start sending out more cases, we get better at it. You know what I'm saying? That's the whole thing. So
Get very less cases in
yeah, exactly. Yeah.
I have a question.
So the values that we mentioned, 170 and 200, are they specific for only MCA or are those values across all
It is
vessels?
primarily done, the research has been done on MCA, AC.
MCA, ACA.
MCA and
MCA and AC.
See, ACA is not that easy to get because when you're doing a transfer report,
See, and
see the
plane
vessel
at
that
which you
comes
put-
parallel is the MCA
Yeah.
straight in front of you. ACA goes anteriorly.
the angle at which we are seeing the ACA is more horizontal.
Yeah.
You're
So
seeing it
what
from
I
this
want
angle.
to ask is, for whatever reason, if we cannot get the MCA, then these same values cannot
MCA you
be,
will get.
interpreted.
MCA you will definitely get.
MCA you
ACA
always
you may
get.
not,
ACA
MCA you will
challenge.
definitely get.
Oh,
So we always define the MCA for sure.
okay.
MCA is
Fine.
definitely more easier to get. The ACA goes in a different direction. So it goes away from the transducer. So it's a little bit more challenging to get always. Because it looks easy, these pictures look very easy, but to get that circle of Willis is not easy.
See, I said that those are the textbook images.
Yeah.
So, okay. Thank you.
Thank you. Thank you. Thank you all for attending.
Thank you, chairpersons. We'll just have one quick session, one quick lecture before lunch break, for which I would like to call our next chairpersons. Dr. Gaurav Beswal, who's a senior diabetologist at Sir H.M. Reliance Foundation Hospital. And Dr. Savita Khadse, who is the associate professor in the Department of Pediatrics at LDMMC and Sion Hospital. I would request the chairpersons to introduce our next speaker.
So good morning all. It's an honor to introduce Dr. Abhishek Kulkarni sir. Dr. Abhishek Kulkarni is a leading pediatric and adolescent endocrinologist working at leading hospitals of Mumbai. He has a keen interest in academics, research and clinical care. After his graduation in Grant Medical College and training from SGPGI with the Royal College of Child Health Fellowship, he started his practice, and I specifically like to mention that he identified the unmet need of thalassemic children for endocrinological issues, and he started first pediatric endocrine clinic in LTMC GH, Harvard Institute, with 150 children, screening them for endocrinological issues and managing them. And it's a great honor to hear from you, sir, after a long time.
Thank you. Thank you, Dr. Shweta Bansal, for having me here at this wonderfully conceived, organized, and conducted CME. So, identifying and managing endocrinopathies is a niche area in patients with transfusion-dependent thalassemia, and a small part of the much larger picture. I mean, that is what I'm going to be trying to emphasize in these 15 minutes or so, is to look through the prism, but not miss the larger picture. So especially in developing countries like ours, where the challenges are far more than just managing endocrinopathies well. Now, why are we speaking about them is more than 80% of these children, transfusion-dependent hemoglobinopathies, particularly thalassemia, would have minimum of one endocrine complication or even more. And they significantly impact the overall health and quality of life. So the endocrinopathies that I'm going to talk about in order of importance or occurrence are growth retardation, hypogonadism, diabetes mellitus, or I'd like to call it as glucose intolerance in the current era, hypothyroidism, low bone density, parathyroid dysfunction, and adrenal insufficiency of either type, central or primary. Now, most of these have common factors or common reasons why they occur. The first one being chronic anemia and tissue hypoxia. Second, iron overload, direct infiltration, or oxidative stress-induced cellular damage, hepatic dysfunction, HCV infection in the transfusion era, genotypic predisposition, and splenic removal. So these are common to most of the endocrinopathies. I shall emphasize if there are any additional factors when we talk specifically of individual endocrinopathies, but these are the commonest reasons why the endocrine system gets involved in patients with transfusion-dependent thalassemia. Now, a word about iron overload or hemosiderosis as to how it leads to
or the cause of the problem is either direct infiltration or free radical formation induced lipid peroxidation causing mitochondrial, lysosomal, and sarcolemmal damage. And this is probably the reason why there are no reference ranges for pituitary ion overload as yet, because the physis is far more susceptible to the effects of iron in addition to direct ion infiltration vis-a-vis the other organs. So there is an added component of free radical formation related damage, which is very stark when you're talking of the physis. And this is probably one reason why we do not have quantification of pituitary ion load and its correlation with the biochemical or clinical manifestations. Now, as a thumb rule, what we tell our fellows is complications are often encountered when ferritin levels exceed 2000, but there are various thresholds which are organ specific. And also, it's important for us to understand that rather than the one-time ferritin level, it's the cumulative exposure that is more important for development of endocrinopathies. Short stature and hypogonadism are the most common ones encountered, and they're often interwoven or interexistent. And the hypophysis is particularly susceptible to iron deposition and free radical formation. We also need to understand that the pituitary sensitivity is varied from one axis to the other. So it's the growth hormone, the somatotropes and the gonadotropes which are most susceptible. And the thyrotropes and corticotropes are relatively resistant. So the general teaching is if it's hypogonadism, it's more likely to be central, which is hypogonadotropic. And if it's hypothyroidism, it's more likely to be primary. But eventually, as the patient ages, the hypothyroidism would have a central component as well. And that's why when we look at thyroid dysfunction in a transfusion-dependent thalassemic, in the initial years, it's very easy to just titrate the dose of thyroxine based on the TSH. But as the patient starts living longer, we need to be alert and aware that this could be physis. Physis could be contributing to the thyroid dysfunction. And these patients can decompensate if concomitant adrenal insufficiency is missed. So as they live longer, challenges start to increase and clinicians need to be more aware and alert during their visits. So that's exactly what I wanted to emphasize is hypogonadism is more likely to be hypogonadotropic, whereas thyroid dysfunction is more likely to be primary. But as you age with transfusion-dependent thalassemia, there's always an interwoven component of central and primary organ involvement. Now, most of the factors are common, but we need to understand that growth failure in thalassemia is multifactorial. And pediatricians and clinicians caring for these children must not always equate growth failure in thalassemia to growth hormone insufficiency. So prevalence of growth hormone deficiency or insufficiency varies between 25 to 50% of these patients, whereas growth failure is universal in the second decade of life. And it's multifactorial. Again, anemia, hypoxia, ferritin-induced damage, both direct and free radical induced. Another important feature is hepatic dysfunction, which leads to relative growth hormone resistance. So these patients are not going to respond to growth hormone the way patients without comorbidities respond to. That's because of the defective hepatic production of insulin like growth factor 1. So the expectations while being on growth hormone therapy must be realistic, must be discussed with parents prior to initiation of the therapy. Concomitant hypogonadism during the teens is a common cause of insufficient response to growth hormone therapy. Hypersplenism, zinc deficiency, and vertebral deformity. So it's not uncommon for us to see the older thalassemic children to have disproportion in addition to short stature. That's because of the specific impact of the condition on the vertebral bodies leading to flattening. And I'm obviously not the right person to be speaking to hematologists, but also desferrioxime related vertebral anomalies are to be kept into account when you use them prepubertal. So management, it is very, very important before subjecting these children to growth hormone testing. Like, let me emphasize again that growth retardation is multifactorial, and in 50% of the cases or more, the growth hormone axis is sufficient, mostly in the first decade of life. So you need to Optimize all the other confounding variables as much as you can. Ensure euthyroid and eucortisolemic status before you take them up for growth hormone testing. Also, priming them with sex steroids if they are in the pubertal age group is very important, lest you will end up labeling them growth hormone insufficient wrongly. So these tests must be performed by clinicians who are usually doing it or have reasonable expertise in doing so. Addressal of coexistent hypogonadism is a must. And it's very important for clinicians to stratify patients into GH sufficient versus the ones who are deficient prior to considering the option of offering them somatropin or growth hormone. We do not have an option of not offering them growth hormone if they're GH deficient. But the ones who are sufficient, I think we have a lot of other challenges prior to considering just statural optimization. Now, gonadal dysfunction is probably the commonest. It's probably more common than growth hormone insufficiency. Definitely more common than growth hormone deficiency in these patients. And as I mentioned, initially it's hypogonadotropic hypogonadism. And later, as the patient grows older, we often see an added component of primary gonadal insufficiency, which impacts fertility by then. Iron accumulation in the pituitary in the first 10 years of life is what has been linked in most studies to have a strong correlation with hypogonadotropic hypogonadism. Next is iron deposition in the gonads as the patient gets older. Iron deposition in the adipose tissues leading to disordered leptin signaling, which affects the HPG axis, has been increasingly recognized. So it's not just direct impact of the iron on the pituitary and the gonadal tissue, but also iron infiltration of the adipose tissue, highlighting the important role of leptin in signaling of the HPG axis has been increasingly recognized, though unfortunately, it does not change the line of management in these patients. And again, my hematologist colleagues would agree that inherently these patients have favorable or unfavorable genotypes, which predispose them increasingly to endocrinopathy. So for hypogonadism, it's the beta 0 phenotype. So manifestation is age dependent. So it could come with delayed pubertal onset. The commonest one in tertiary care settings is usually incomplete pubertal progression or pubertal arrest. So there's some form of pubertal onset, but we need to be vigilant and look at them longitudinally. And invariably, these patients have pubertal arrest or incomplete progression or suboptimal progression. In the older adolescent or the young adult, they could just present with deviant sexual function, diminished fertility reserve, and obviously low bone mineral density. So while we look at bone health, particularly the osteoid, one must not forget to address the hypogonadism before interpreting the bone mineral density in these patients. So androgenization or estrogenization, metabolic and bone osteoid homeostasis, and fertility preservation are the objectives in the endocrine clinic while dealing with hypogonadism. So generally, pubertal induction and maintenance with sex steroids is offered to patients in their early years. But in the current era, it is not uncommon for us to offer patients a combination of recombinant FSH and human chorionic gonadotropin to increase the gonadal size and also optimize the Sertoli cell function in the male to enable them to have spermatogenesis. So this is feasible only in the early years because as these patients age, the Sertoli cell reserve is exponentially on the decline. So if there is ever a discussion on fertility and gamete preservation, it has to be done prior to the age of 17, or the time when we offer it to patients is between 14 to 17 years. And the therapy is also individualized based on the testicular volume at presentation. So the smaller testes usually need priming with recombinant FSH before human chorionic gonadotropin is introduced, whereas those coming with pubertal arrest and testicular volumes of 5 or 6 ml can be offered human chorionic gonadotropin directly, and spermatogenesis can be expected in 20 to 45% of patients. So disorders of glucose homeostasis, the next important thing, and we don't talk of diabetes anymore, we talk of impaired glucose tolerance, or rather we like to talk of dysglycemia because we moved from diabetes to time in range, and now we speak of tight time in range, which means even in the euglycemic range, we like to segregate dysglycemia from the tight time in range. And unfortunately, our conventional markers like glycosylated hemoglobin won't work very effectively in thalassemia. That's because the composition and the glycosylation of hemoglobin is both not normal. And even other markers like glycated albumin, fructosamine have very short or relatively short half-lives, 2 or 3 weeks. So we do not have a marker which accurately tells us about long-term glycemic control in these patients. When we were trainees, we were always taught to use boronate affinity chromatography as a measure to look at the glycosylated hemoglobin. But even that would not obviate the fact that these patients keep getting regular transfusions and the erythrocyte half-life is very short. So even that would not accurately estimate the glycemic reserve. So in the current era, we are forced to rely on either OGTTs, which are cumbersome to perform and cannot be done more than twice or thrice a year, or then where resources are not a constraint, we would like to use continuous glucose monitoring systems. But again, they come with their own caveats, because even the interstitial fluid glucose, which is measured by the systems, is affected in patients with thalassemia. So glucose monitoring comes with its own caveats in these patients, but it's extremely important to do so because we can pick them up at the phase of dysglycemia. And why I'm speaking for it is there is role for improving insulin sensitivity in these patients, and that's the reason why in most Western cohorts and studies you will see up to half of these patients with dysglycemia being treated with metformin. And how does that help? Is it reduces the peripheral insulin resistance, which occurs due to deposition of iron in the skeletal muscles. Also, the inflammatory milieu with cytokines like TNF alpha contributes to peripheral insulin resistance, and the hepatic insulin resistance because of the existent dysfunction is also assisted by metformin. So in thalassemia, the dysglycemia is a spectrum. Your patient may present with insulinopenia, not absolute insulin deficiency, and in such patients there may be role of use of DPP-4 inhibitors. So if you have a patient who's relatively insulinopenic, you're going to look at the role of DPP-4 inhibitors, which are basically incretins, before the beta cell reserve is exhausted. If you see a significant component of insulin insensitivity, there is role of metformin. And once the insulin reserve is depleted because of pancreatic dysfunction or beta cell destruction, then you have no choice but to insulinize these patients, either with multiple daily dose injections or with continuous subcutaneous insulin infusion. So these are the mechanisms. One added knowledge that we've gained in the last 10 years is splenectomy also is a risk factor for dysglycemia. That is because it facilitates pancreatic adipose tissue infiltration. So this is something new, and that's what I said. Most of the factors are common, and for diabetes, obviously, there are certain genotypes which predispose children to dysglycemia. Now, though iron accumulation triggers autoimmune responses, a large number of patients would never manifest the conventional type 1 autoantibodies. So both hypothyroidism and insulin-dependent diabetes in thalassemic patients may actually have positive autoantibodies, but there are a small section of patients where the autoimmunity is triggered again by the iron-induced free radical damage. But majority of the patients would be autoantibody negative. But in our experience, we have dealt with patients who have coexistent morbidities. So initially, it's iron-related free radical damage leading to autoimmune activation, and these patients test positive for the conventional type 1 autoantibodies. So the protocol is, once the child is 5 years, you perform a fasting sugar. And if you have a fasting sugar of more than 110 milligrams per deciliter, you subject the child to oral glucose tolerance test. So this is the current existent protocol. However, this might undergo a change because we are increasingly realizing that, like type 1 diabetes, patients with transfusion-dependent thalassemia may actually depict loss of the first phase insulin response. So it might actually be fruitful looking at the post-glucose response, which will be blunted first rather than the fasting glucose. So this protocol may actually change in the next year or so, where guidelines would talk of subjecting children to oral glucose tolerance test, because it's the loss of first phase response, which is the first sign of decompensation of the beta cell. So I already mentioned that, how could we prevent it? It's all about optimal chelation, compliance, and preventing hepatic dysfunction. But metformin, yes, where you feel that insulin sensitivity could be affected, incretins prior to exhaustion of the beta cell reserve, and insulin therapy once the beta cell reserve is exhausted. Now, thyroid dysfunction, almost after the first 10 years of life, half of the patients would have it. Initially, it is almost always subclinical, where your free thyroid hormone levels are well compensated within the normative reference ranges, but the TSH is elevated. Again, the policy that is used in our unit is to treat subclinical hypothyroidism. So, our eminent radiology colleagues were speaking about transcranial Doppler, and there have been studies which have looked at carotid intimal thickness in patients with thalassemia and subclinical hypothyroidism, and outcomes have been better over long-term follow-up, where patients with subclinical hypothyroidism have been treated. So we've revised, though if you look at the conventional guideline, it says overt hypothyroidism or subclinical hypothyroidism should be treated as soon as the TSH is greater than 10. But then the guideline leaves a loophole that in cases with TSH less than 10 and comorbidities, it does not specify which ones. So most of these patients are comorbid and quite morbid. Morphologic alterations in the thyroid gland, presence of autoimmunity, treatment is initiated early. So generally, our policy is to treat patients when the TSH is above 5.5 on 2 or more occasions. Now, and as they grow older, do not forget the added component of central hypothyroidism. So nothing changes in the replacement, but surveillancing the kid for associated adrenal function becomes very, very important, because if the child has adrenal insufficiency, even if it is subclinical, in the morning hours, they can decompensate after taking their thyroxine. They suddenly go low, they have low blood sugars, they get limp. So you need to be careful. You need to warn the parents that it's not just about thyroxine replacement, but the modalities that leads to the disease. Rarer, maybe up to 30% of patients present with parathyroid dysfunction, and most often they are detected when the fellow or the postdoc is taking the blood pressure. They don't come with, the very, very severe ones come with tetany, carpopedal spasm, or a seizure. Most of them are subclinical, and they are picked up when the blood pressure cuff is left on and the fellow gets busy with something else where the latent tetany manifests. So, and also there are no written guidelines as to how frequently should you be performing the parathyroid hormone level in these patients. But it's always good to elicit latent tetany. It's also always difficult because these patients have concomitant liver dysfunction, low albumin levels. So the important thing that we need to look at is the corrected calcium and not total calcium. Doing a blood gas and trying to look for the ionic calcium would have its own problems. So a difficult exercise, but the simple message is we need to look at a good total corrected calcium at least 2 times a year, ensure calcium supplementation. And if you have a suspicion of borderline low normal calcium levels, you must have an elevated parathyroid hormone level. So these patients won't come to us with low parathyroid hormone levels, but they'll come to us with inappropriately normal parathyroid hormone levels in the face of hypocalcemia. So you won't see the counter-regulatory rise of PTH, which tells you that the blunting has already begun. And it's often said that it's good to document cranial calcification prior to starting active vitamin D analogs, because once you start them, they are for life. And what needs to be looked at is avoidance of hypercalciuria. So generally the targets are...
Sorry to interrupt the last.
Yes, so I have 2 slides more. So the general dictum is to keep the calcium around 8.5 milligrams per deciliter, the corrected calcium. So low bone density, again, direct effect of the expansive bone marrow, iron accumulation, inhibiting the osteoid maturation, endocrinopathies, typically hypogonadism, vitamin D deficiency, liver disease, and cardiomyopathy. These are the reasons for low bone mineral density. It is recommended that we must do a DEXA scan once a year from the age of 10. It is also very important when we refer these patients for DEXA scan to have a Z score and not a T score in the pediatric population. The Z score must be matched up for the chronologic age, the bone age, and the height age of the child, because these children are short and they are going to be erroneously the low bone density is going to be erroneously overestimated. So it's always important that the endocrine unit always adjusts the BMD for the chronologic age, bone age, and the height age. And bisphosphonates are used in children, including those younger than 10 years of age. One important point is when the low bone density is believed to be due to hypogonadism, it is still recommended to use bisphosphonates in addition to sex steroids, especially testosterone when we are dealing with the male, because testosterone alone in the absence of bisphosphonates also alters the vertebral morphology unfavorably. So last one, very, very rare, prevalence of up to 25% median. Again, these patients usually never come with clinical features but decompensate during stress situations. And it's very rare for us to keep a patient on maintenance hydrocortisone, I mean transfusion dependent thalassemia, but during stress situations, if they do not mount a response, so if these patients have fever, they have come for a transfusion, that's the best time to check their cortisol levels. And if they're less than 12 or 15 micrograms per deciliter, we know the patient is not mounting an adequate stress response. So rather than a basal state deficiency, it's the latent or absence of stress response which would mandate stress glucocorticoid replacement. So to sum up, more than 80% of those living with transfusion-dependent thalassemia suffer a minimum of one endocrine complication. They significantly impact the overall health and quality of life. We need to anticipate, screen, and recognize endocrinopathies from a young age. Pathogenesis is multifactorial and usually involves chronic anemia, tissue hypoxia, iron overload with other specifics. Importance of compliance, optimal chelation therapy, effective monitoring systems, especially in countries like ours, should be emphasized and are reaffirmed. Thank you very much, ladies and gentlemen.
Thank you, Dr. Kulkarni. That was excellent, and I think covered all the endocrine therapies quite effectively. I think just to highlight, it's important to, we saw that slide that 80%, it's an overlap. It's important to just anticipate it and treat it early on, bring it up early on. So firstly, any parting messages or any highlights that you would have?
Maybe our hematologist colleagues, maybe Shweta can guide us, and especially with glucose tolerance. Now, I refrained from using diabetes and I was, wanting to harp on glucose tolerance is, say, dual chelation or intensive chelation therapy has shown to improve glucose tolerance in these patients. So I'm not saying it is reversible, but we can definitely say that decompensation of the beta cell can be delayed. So and the same may hold good with the physis, but the physis is far more sensitive. When we trained, we were always taught that the gonad is the most sensitive endocrine organ, but now we know the physis is far more sensitive. So we probably may not be able to delay or reverse the physis, the infiltration related damage, but pancreas probably yes. So intensification of chelation, and that's why the talk of dual chelation at diabetes conferences, but you guys know best what other ADRs it could have on the child. That could delay onset of diabetes in these dysglycemic patients.
Questions from the audience?
Abhishek, excellent lecture. We are learning so many things from this lecture. And my question is regarding when we are managing this patient. In our institute, many of the patients are very well labeled, very well preserved. So, and we don't see, we do their thyroid testing, maybe thyroid testing, we don't do it, they are completely normal. So, what is the ideal age without any complications? At what time we should be sending everything?
So generally, if in the handouts we've made a small flow chart. In the first 5 years of life, it is growth, but again, growth failure is usually 7 and above in the type of patients Dr. Shweta is talking of, those who are very well chelated. It's primarily the glucose tolerance in the first 5 years, thyroid dysfunction, bone mineral density, growth retardation, hypogonadism is all after the 10th year. So generally in the first 10 years, it's growth and glucose tolerance. But again, in patients who are genetically predisposed, now unless you have a specific genotype that you have ascertained, these patients come in very early. So that is why we are, it's difficult to explain to parents when a 5 or a 6-year-old who's very well chelated comes with a thyroid dysfunction or say glucose intolerance or diabetes. And the simple answer that we offer to patients is your child is genetically predisposed. He has an unfavorable genotype. And add to it, it's not always, if you look at various papers, and I was doing my reading as usual before a talk, and it was very, very well emphasized that it's not always the ferritin level or the cumulative exposure, and also the iron overload. It is very organ specific. So for the pancreas, it may correlate. I mean, amongst the endocrine glands, the pancreas correlates best, the T2 star iron overload. The others, there's no correlation. So someone who has a very bad MRI finding is actually clinically and biochemically asymptomatic and unremarkable. So I think it's genetic predisposition, but in the first 10 years, primarily growth and glucose tolerance. Thank you. Thank you very much.
Thank you.
Thank you, Doctor, for this amazing session. I also thank Dr. Gaurav and Dr. Sarita.